Hello students, welcome to Distinction Learning Platform, and on this platform you find educational videos, you find a lot of stuff. And to make the story short, let us start talking about septic arthritis in this video. Alright, and there is also an important thing that you need to do so that you can support our channel by simply liking the video as well as to comment in the comment section. Apart from that, also make sure that you click on the link in the description that will take you now to our website where you find other educational videos. Make sure that you do that, okay? Now, let us start talking about septic arthritis. Now, in this video, we're talking about the diagnosis of septic arthritis as well as general management, because remember, we talked about septic arthritis in details, the causes, as well as we talked about the pathophysiology. Make sure that you watch that video. All right. Now, just to recap, we said what is septic arthritis? We said septic arthritis, it is just an inflammation of one or more joints. So inflammation of joints caused by what? Caused by microorganisms. That's what we call septic arthritis. You need to remember about that. Now, this inflammation of joint caused by microorganisms, but if you talk about the anatomy of the joint, remember to say the first or the structure where septic arthritis firstly going to involve is what we call the synovium or the synovial membrane. That's where those microorganisms likes to cause inflammation first, then it will start now affecting the surrounding structures in the joint. So now, that's from there, because there is also another important disorder or joint disorder that also affects what we call the synovium. What is that? We call it synovitis. So we need to know how to differentiate septic arthritis from what we call transient synovitis. So let us just use this. Okay. So what we're simply saying is that before you go to diagnosing septic arthritis, you need to know how to differentiate transient synovitis from septic arthritis. So we're talking about transient SRCTS, transient synovitis. So transient synovitis, that's from the word itself, it doesn't stay long, okay? It's more like it's not caused by microorganisms, it's caused by maybe someone has some genetic predisposition, or maybe some autoimmune infection, autoimmune disorder, or maybe they had an upper respiratory tract infection which was cleared. Now those antibodies that are within the blood vessels are the ones that are causing inflammation to the synovium. So this one is very, very similar to septic arthritis, but what we need to understand is that transient synovitis, it is not an infectious type of joint disorder. We need to know about that, okay? All right. Now we go to the diagnosis. So diagnosis, we can categorize the diagnosis of septic arthritis into two: the pediatric population diagnosis as well as the adult population diagnosis. Okay. So in pediatrics, we've got a certain criteria that we follow, which we call Kocher'S criteria. But in adult, we don't have that specific criteria, but we use the two important things or the criteria that we need to follow: the rule-in criteria that we talk about and the clinical triad. So these help us to diagnose septic arthritis in adult. All right. So now let us start with the Kocher'S criteria. So Kocher'S criteria, basically it is the criteria that's going to be used in pediatric population, okay? And it's going to have 4 parameters, okay? So let us start with the first one. The first one, remember that we can have, the first one, we can have fever, okay? But this fever, it has to be greater than 38.5 degrees Celsius. But if you are using Fahrenheit, you can say greater than 103 or I mean 101.3 Fahrenheit, degrees Fahrenheit, like that, okay? Whatever. So just not to say, if you are trying to suspect septic arthritis, most of the time fever is going to be present. If you remember from the pathophysiology, we said fever comes about because there are some interleukins that are going to be produced by the inflammatory cells in the joint there, so that those interleukins like interleukin 1, tumor necrosis factor alpha, those they go to the hypothalamus. That's where now the fever is going to come from, okay? So that is the first parameter, fever. The second parameter is erythrocyte sedimentation rate, ESR, which is greater than 40 millimeter per hour, okay? Erythrocyte sedimentation rate is one of the parameters that is used in Kocher's criteria, okay? Now, what does that mean? So, if you remember to say erythrocyte sedimentation rate is an inflammatory marker, okay? Indirect inflammatory marker, because it's going to be raised if someone is having systemic inflammation, okay? So, that is a very, very important marker. And if you look at the erythrocyte sedimentation rate, it is used in the treatment monitoring, okay? If you want to see the treatment is successful, make sure that you are going to be looking at the ESR number. If it is reducing like that, basically it's going to be sure that treatment is now successful like that, okay? Make sure that you understand about that. But if you are trying to diagnose it, septic arthritis, the ESR has to be greater than 40 millimeter per hour, okay? We go to another one. Non-weight bearing, okay? Non-weight bearing, what does that mean? It means that now, if someone is having like septic arthritis on a certain joint, so there will be pain or tenderness on that joint. Basically, if those people or patient try to stand, that tenderness is going to be increased. Reason being because you are stretching the joint capsule if you try to stand. So there will be non-weight bearing on that affected joint. Very important point as well. So non-weight bearing is one of the factor that is considered in Kocher's criteria, okay? Another important factor, okay, WBC, white blood cell count. So white blood cell count is one of the Kocher's criteria factor, and it has to be greater than what? It has to be greater than 12,000. Okay, cells per macroliter or per deciliter. So let's just say macroliter or per deciliter like that, okay? Oh, let me just say the simplest one. Let's just say millimeter to the power 3, okay? So WBC or white blood cell count has to be greater than 12,000 cells per millimeter to the power 3, okay? That should be an important indicator of what infection in the body. You need to understand on that. So this is what we call Kocher's criteria. Again, just to revise whatever we're talking about, we're saying the first factor, important factor, is fever. Fever has to be greater than 38.5 degrees Celsius. ESR, erythrocyte sedimentation rate, which is greater than 40 millimeter per hour. The non-weight bearing, as well as white blood cell count, which is greater than 12,000 cells per cubic millimeter, okay? We need to understand about that. Now, there is a scoring system that we use, okay? So we need to use this, okay? We need to use these factors, okay? So that you can at least maybe, what can I say? so that you can know the probability of septic arthritis. Okay, so you can use these factors. Maybe someone, if that person is having one factor out of these, what is the probability of suspicion of what? Septic arthritis. What is that? So then we're going to use this scoring system. Okay, so let's say, so we're going to use red here. Let's say if someone is having one factor, this factor, the out of 4. So if someone is having 1 out of 4 factor, okay, maybe that person is having fever, ESR, or non-weight bearing, or WBC count, like that. One of them, then what will be the probability of suspicion of septic arthritis? The probability of septic arthritis, 1 out of that, it will be 3% probability. So let's just say probability of what is suspicion, which is not that much. Okay, if that someone is having a fever, basically you're just going to say, okay, the probability of this person having septic arthritis is 3%. Okay, now what about if someone is having 2 out of 4? Okay, 2 of these factors. Okay, then what will be the probability? Now the probability will increase up to 40% probability. Okay, then what about if they have 3 out of 4 factors? Okay, then they're going to have about 93%. Okay, probability of septic arthritis suspicion. Now what about if they have 4 out of 4 now? 4 out of 4, then the probability of having septic arthritis is now about 99. It will never be 100%. It will be now, okay, probability will be now 99%. So if someone is having about fever, like all of these factors, then the probability will be about now 99%. Okay, make sure that you take note of that. Okay, now I need to add on something which is also important. So there is also another modified criteria in pediatric patient. There was this scientist called Kide. Okay, so let's just say this Kide added another criteria. Okay, this one added the 5th one. Okay, this one, instead of just having 1, 2 up to 4, then he added one criteria or one factor. He added to say, okay, we need to add CRP. So do you know CRP? What is CRP? CRP is so CRP means C-reactive protein. So he added to say, okay, C-reactive protein is a sensitive marker. If you remember to say, I said ESR, erythrocyte sedimentation rate, is an inflammatory marker. Also, CRP is an inflammatory marker, okay? But this one, CRP, is so sensitive compared to ESR when it comes to what? Measuring the inflammation or the rate of inflammation, okay? So no wonder it's very important to add on what is CRP. And if you remember, I also said to say ESR, it is a factor which is important in what? Monitoring the management, okay? If you are managing this septic arthritis, then you try to know the successive management of that septic arthritis using maybe some antibiotics, whatever you are doing, do that. Okay, then it has to be decreasing. But I said this is not so sensitive compared to CRP. Okay, CRP is going to what? Increase rapidly, and also it's going to be decreasing rapidly. So this one is used in acute type of septic arthritis, and this one is used in more like subacute septic arthritis, as well as the chronic septic arthritis most of the time. Okay, so now this CRP has to be greater than 2, okay, milligrams per what? Deciliter. Or if you want to say like the other number, if you want, you can say greater than 20 milligrams per liter, like that. So either way, here is just deciliter, here is just per liter. 20 milligrams per liter or 2 milligrams per deciliter. It has to be greater than that. Okay, that's what he said. So meaning that if you have, let's try to have the meaning about this. If you have CRP and one of these criteria is said to say, if you have CRP, okay, and you have maybe plus fever, let's just pick one, maybe you have fever now, what would be the probability? Because if we are having now 2 factors here, we are having this one and also this one. 2 factors here, 2 out of 4, it was 40. Now, since CRP is so sensitive, it's never going to be 40, to be now 75. So what I'm saying is that if you have CRP and one of the factor above here, then it will be now more than 40%. It will be now 70 to 80% probability of septic arthritis. So what I'm simply saying is that if you say 2 out of 4 with the CRP like that, okay, CRP one of the factor and one of the Kocher'S criteria factor, then the probability of having septic arthritis will range from 70% to maybe around the 80%. Okay, that's what he said, this guy. Okay, so this is now the diagnosis in pediatric patient. Make sure that you pay attention to that. Okay, now let's go to the diagnosis of septic arthritis in adults. How do you diagnose septic arthritis in adults? Do you know that? Yes, we know, because we've got now 2 criteria here. We've got the rule-in criteria and the clinical triad. So rule-in criteria, what does it mean? So rule-in criteria, it means that now you are going to aspirate the synovial fluid which was affected, okay, or on this as affected joint. So here, rule-in criteria, we're just talking about the things that is going on with the synovial fluid, the amount of white blood cells that are there, the color, the quality of that synovial fluid. It is all about what is the rule-in criteria. Okay, so let's start with the first thing that we look at it in the rule-in criteria. Okay, so look at the white blood cell count. White blood cell count. Basically now, here we are going to specify that it's a differential count that we consider here. So we're going to look at the PMN, polymorphonuclear leukocytes, so which we call neutrophils. So here we count the number of neutrophils, so that we see how much of neutrophils that are there in the synovial fluid. So if the number of neutrophils is greater than 75%, so let us use red here. If the number of neutrophil is greater than 75%, okay, now we're going to consider the septic arthritis there. Okay, but more often it's shown, although it is greater than 70% in like the minimum thing that we need to consider, but in most cases we're going to find to say the number of neutrophils, they are more than 90% in most of the cases. Okay, so we are saying the minimum number that we can say, or the percentage is 75% and above. But in most cases, they find to say the number of neutrophils that are in the synovial fluid, they are more than 90%. Okay, we need to know about that. The next, so glucose and lactate. So they also consider lactate or glucose. Okay, they also consider lactate and or glucose. So this one now, we're going to have less than 50% of glucose or lactate in the synovial fluid. Remember that synovial fluid contains a lot of glucose there, and if you look at the quantity of glucose in the synovial fluid and in the serum there, they are just like almost equal. Okay, almost equal. Now what happens is that now if there is an inflammation there or the infection there, those bacteria or any microorganism in the synovial fluid, they'll start using up glucose. If they are using up glucose, what do you think to the number of glucose or the amount of glucose in the synovial fluid? it's going to what? To decrease significantly. No wonder we are saying it's going to be, has to be less than 50% of that of what? A serum glucose or lactate. Okay, another one. Okay, another factor that we can need, that we can put here is gram stain. Okay, gram stain. So we're going to have what? A positive. Okay, so because the microorganism is there or the bacteria is there, remember that the common cause of septic arthritis is bacterial in origin, which we said, if you remember, that was what? Staphylococcus aureus. Okay, so if you get that aspect, then we try to get cultures from there. If we get cultures, make sure that we're going to have positive culture there, and we're going to stain that aspect so that we can have gram stain, and most is going to be what? A gram positive. Okay, what else? And the last important factor is what? Which is now the WBC count. Okay, not with differential, which we're talking about this greater than 75%, but it's the number of all white blood cells in the joint aspirate. Okay, so and this one has to be greater than, let us use red. Okay, so it has to be greater than 50,000, which is a lot, cells per macroliter. Okay, so it has to be greater than 50,000 macroliter. This one. Okay, that is about the WBC count. And this one, basically, if you have these 4 factors present, basically that will be going to tell you that people are having the septic arthritis, and this is the gold standard in our adult. They use this one as well. You can use this one also in pediatric patient. Okay, if you are unable to be, if you are not sure that okay, this one is septic arthritis, using this criteria. Okay, but you can also use joint aspiration or the root-in criteria like that. Okay, you can use this one. Okay, now another one, which is the clinical triad. Okay, so we can also use a clinical triad to in adult if you don't want to, because this is more like invasive. Okay, this is more like invasive, where you are going to do the joint aspirate using the needle like that. Okay, if you don't want to do invasive procedures like this one in adult, you can just simply use the clinical triad to diagnose septic arthritis. Okay, so now what is this clinical triad that you can use? The first thing that you can do is this one. Okay, so first of all, you need to look at the non-weight bearing. Okay, non-weight bearing or maybe joint stiffness like that. Okay, they are unable to use their joint because of that tenderness or severe tenderness that they are feeling. That's the first clinical factor that you need to consider. Another one that you need to consider is this one. Okay, joint pain. So let's just say joint pain or monoarticular joint tenderness or pain. Okay, monoarticular joint pain or tenderness. Remember that septic arthritis is more like a monoarthritis. It's only affecting one joint. So if you see tenderness on just one joint, we see non-weight bearing, as well as the last important factor, which is this one. Restricted, passive, or active range of motion, now you are going to suspect septic arthritis. So if you have this thing present in a certain patient, basically it's going to give you high suspicion of what? Septic arthritis. Non-weight bearing monoarticular joint pain, as well as restricted passive or active range of what? Motion. If those factors are present, basically you are going to have high suspicion of septic arthritis. Okay, so these are the things that you can do. Okay, now the other important thing that we need to know, if now you have the clear picture of on how you can diagnose septic arthritis, now what is the best way in which you can manage septic arthritic patients? Okay, so these are the things that you can consider. Now this is just a general management, not the specific management. You need to take note of that. So general management simply means that the thing that you can do in order to treat the septic arthritis in just not in details. Okay, general management. So if someone comes in, you suspect, you now diagnose septic arthritis using either criteria here. Now what are you supposed to do first? So someone, if they come, the rule is first admit to those patients. Okay, so make sure that you admit the patient suspicion with what is septic arthritis. Why? Because septic arthritis, it is an orthopedic emergency. So make sure that you admit that patient and stabilize. That is the first initial management. So before you do all this, first of all, you admit the patient. So we can just write something here. Admit. Okay, admit and stabilize the patient. So admit and stabilize patients. Okay, so that's the first important thing that you need to do, stabilize. You do your ABCs, all those things. Okay, then after you do that, now you need to consider now pharmacological management as well as what? Surgical management. Okay, so we'll start with the pharmacological management that you can do. Then next we'll talk about what? The surgical management. What's the first important pharmacological management that you can do? You can do this one. Okay, you can do this empirical and biotic therapy. So let's just say AT. So empirical antibiotic therapy, that's the first thing that you can do. Okay, after you do the surgical management, maybe you do the first, like you do the joint aspect like that. Then after you do the joint aspect, then that's when you can do now empirical antibiotic therapy. Now empirical antibiotic therapy, what does it mean? It means that now these antibiotics that we are going to be giving to those patients, they are non-specific, because culture, we don't have culture. Okay, we don't know the microorganism that is causing that septic arthritis. So now we're going to give the broad spectrum antibiotics as empirical therapy. Okay, so empirical therapy doesn't target the microorganism that is affecting the joint, but rather we're just giving it so that maybe somehow we're going to cover that and the microorganism that is causing septic arthritis. Okay, but it's not specific to that. So that's what we call empirical therapy, where you are going to use which we call vancomycin. So here mostly for empirical therapy they put vancomycin plus maybe we're going to add on ceftriaxone. Okay, ceftriaxone. So vancomycin is going to cover the gram-positive bacteria and MRSA, but ceftriaxone covers the gram-negative bacteria. It is important. Okay, then the next important thing you're going to do now, the what? Target therapy. Target antibiotic therapy. So we're going to now do target antibiotic therapy. As you can see, just from the way target antibiotic therapy, basically now here you have culture. Okay, you have culture. After you do the joint aspect, that aspect, now you did culture, you waited for culture, then after culture comes back, then you are going to know the microorganism that is affecting the joint. If you know that it is Staphylococcus aureus, you can give them vancomycin, or you can continue vancomycin plus ceftriaxone. Okay, If there are other microorganisms like Kocher'S, you can add on some other antibiotics. Okay, you need to know about that. So target therapy, now you have culture. Empirical therapy, you don't have culture there. Okay. Then after you do this pharmacological therapy, then you go to surgical. Surgical, that's a definitive management of septic arthritis. Why? Because if you're just giving antibiotics alone, basically you're not going to eradicate the microorganism in the joint. Why? Because those antibiotics can't penetrate and enter into the joint cavity there because of the pressure that has built in the joint space. Okay, so now you need to do surgical management, which that includes, the first important one is drainage. Okay, surgical drainage. So surgical drainage was decompression, joint decompression. So surgical joint decompression. Okay, so surgical joint decompression, which is very, very important. Now on surgical joint decompression, we are going to have the procedures that they do depending on the type of the joint that has been affected. Okay, so we're going to have some certain surgical procedures. Okay, we can have here, let me just put it here. Okay, we can have this first one, which let me just do this. Okay, so we have arthroscopic lavage, and decompression. Okay, arthroscopic lavage and decompression. So on this procedure, as you can see, you are going to be decompressing or maybe removing the synovial fluid that has been affected from the joint using like a certain instrument. Okay, you are able to see what is going on inside the joint using a camera. Okay, so in this procedure, basically, you are going to be using a camera so that you can be seeing whatever is happening inside the joint. Then after that, then you are able to see or observe how you are going to be draining the synovial fluid which has been affected. Okay, which is a very, very important surgical procedure, and this is a recommended one. It's the one that they use if someone is having septic arthritis. Okay, and basically this procedure is used in what joint that you can access. Okay, like the knee joint as well as maybe the shoulder joint. Okay, if the shoulder joint is affected or the knee joint is affected, you are able to access those joints, and you can use this one. Now, there are some ways in which maybe the hip joint is affected. The hip joint is very difficult to do this procedure. Okay, if you are unable to do this procedure, basically you can use now open arthrotomy. You can do open arthrotomy. So open arthrotomy, basically you're just now going to open up that joint so that now you can surgically remove those like affected synovial fluid with microorganism. This one is used, mostly it is used in joints that are not easily accessible. Okay, very important point. And the other one that you can do is serial needle aspiration. This one, serial needle aspiration. Okay, serial needle aspiration, basically this one. So this is needle. So serial needle aspiration, basically this type of procedure is used where maybe you get a needle, you are going to aspirate. Okay, you are going to aspirate or remove the synovial fluid, just a little amount of the affected synovial fluid per day, and it's more like it's done daily. Today you remove certain amount of affected synovial fluid, tomorrow another affected synovial fluid, like that, up until now the joint is completely decompressed. You need to understand on that. Okay, so on surgical joint decompression, we've got 3: the arthroscopic lavage and decompression, open arthrotomy, and serial needle aspiration. You need to remember on that. Okay, and the other thing that I didn't put here is, after you do all this, then you can also consider rehabilitation. Okay, so you can consider rehabilitation here. So rehabilitation. Okay, so you can consider rehabilitation here. Okay, so why consider rehabilitation after you do surgical procedure, maybe pharmacological therapy there? Rehabilitation is very important in order to remember that these patients, they are having joint tenderness. So you are going to initiate rehabilitation so that you reduce that pain. Okay, and as well as maybe to make sure that you encourage range of motion, because if you remember, these people, they at increased risk of what? Joint stiffness. Okay, so the joint is immobile for a longer period of time, so you are going to make sure that you encourage range of motion. So what you do here, basically you do some exercise, okay, or physiotherapy exercise. So here we're just going to say physiotherapy. So let's just say physiotherapy, okay, where you just do what is some certain exercise, okay, some certain exercise. And as well as this is going to help as well as in what? Joint pain management. Okay, these are the things that you can do rehabilitation. And sometimes maybe you can also do maybe counseling. Okay, maybe if they have severe joint stiffness which you can't manage, okay, so you can offer them counseling. Okay, so now that's where we end from in this video, and make sure that you study more. Until next time.